All right, it's 1:40, so I just wanted to welcome everyone back and just wanted to give a quick reminder about doing the continuing education credits. I'm going to share in the chat now a link to a Google Doc where if you do want to get the continuing education credit, you just need to put your name, email address, and your profession. Right now, we are certified to do continuing ed credits for MDs, RN, NP, and PAs. So you'll just fill out your information there. You will then receive a post-activity performance survey that will be sent from the Boston Children's CME department email. And then we also ask that you complete our course evaluation, which I will share with you in the chat, and then we'll also email out at the end of the day. So all these links will be shared now, and then they'll also be sent to you later today. And if you have any other questions, comments, feel free to send me an email and I will definitely help you out with that. Rich, I will hand things off to you to introduce our next lovely speaker. Oh, Rich, you're on mute.
Unmute.
There you go.
There we go. For some reason, the host muted me, but now I'm unmuted. So the next speaker is just a joy and a privilege. Renee brings energy and insight and wisdom into everything that she does. We introduced her as part of the core faculty, and you'll probably recall that she delivered a wonderful presentation at the outset of the Academy. Today we've asked Renee, who happens also to be the chair of pediatrics and the pediatrician in chief at St. Christopher's Hospital in Philadelphia. What does it look like, boots on the ground? When you come to work every day thinking about addressing and mitigating social determinants of health. Can you speak to that? So the transition, if you will, from the tour de force that Linda Sprague-Martinez just gave to us, we want to have Renee now bring it to show you what it looks like from her perspective. And I want the Academy participants, as you're listening to this, I want that active voice in your brain while you're processing, saying, okay, and what are the implications for us? What can we do to incorporate this into our work in the next few weeks? So without any further ado, I'll ask Renee to come forward.
Thank you, Dr. Angelelli, and thanks for having me here today. Really enjoyed Linda's talk, and I'm excited, I feel like as I was saying, what an honor it is to be a member of this group and also the interaction. So I'm here to share some experience, but just by evidence by the last talk, I think a lot of you have a lot of wisdom as well. So hoping that we can continue to learn together. So the title of my talk, as Rich mentioned, is really Teamwork in Pediatric Social Determinant of Health Screening. And for those of you that were part of my last talk, if you know me, you know that I know it's a lot of zooming, a lot of talking, so I'm a little bit of a goofball. So I like to have a little bit of humor in my talk, so you have to bear with me. My jokes often don't pass the muster of my teenagers at home, but so I did run some of these jokes by them, but I don't know. I hope you guys can bear with me today. So next slide. So I have no disclosures. Next slide. And so what are we really, in all seriousness, what are we going to do today? Really just wanted, from my perspective, kind of coming humbling after Linda's awesome presentation, was really, as Rich said, to do a little bit of just start our discussion and kind of lead us into the breakouts of the translational piece. So talk about the patient and family needs and how that informs our social determinants of health screening in pediatrics and children's and families. And talk about an approach and planning for that screening, and really just share our team's experience. By no means am I here to profess to be any type of an oracle, but just kind of start the dialogue. And one of the things that I hope we do as well is have fun and learn. That's the next slide there. Should be anyway. Great. And so for me, at the heart of everything that we do, and if you recall, I think on many of our discussions here, and for many of us in our small groups, what we keep to the heart is the patient, right? And I think about my own clinical practice and the public health work I have the privilege of doing. It always comes back to the patient in front of us. And I really wanted to kick this talk off for me. I've been thinking a lot about this, talked about this with the Care Coordination Academy team. And I feel like as I am evolving and growing in my own career, I feel like, it's been amazing to watch. Back when I was training, we weren't even talking public health. We weren't talking SDOH. We weren't talking screening. So a lot of us folks that have been around at this for a little bit, this is all coming of age. And one of the things I wanted to share about our experience today are kind of like the things I wish I knew. And some of the things even in our own team, I feel like we all have to be okay with talking about our successes, our challenges, and things maybe we didn't do so well. So you'll hear today some sobering comments about things that we discovered along the way, and I really want to keep this real. This is a patient of mine who I have consent to discuss this. The pictures won't be shared, but publicly, but this little girl who's much older now, I first met a number of years ago with her biologic mom. And I often think back to how our team, thank God her fate, she's doing really well. But when I think back to some of what had happened in her little life, what some type of a screening. And I think we all probably have stories, but I wanted to kind of, think about a patient that when I reflect on like what could I have done as her primary care doc to maybe prevent her from sustaining some of the trauma, and had it been at a time where we were screening more aggressively in my office. So this little girl was a very fragile preemie, 23 weeks premature, and had been born to a mom who was struggling with some personal issues and some substance abuse issues that I think probably our office didn't identify early enough. And she was witness to some trauma while she was doing, kind of growing as a fragile preemie. Early on in her toddler life, witnessed an altercation and stabbing of one of her parents. And later, subsequent to that, actually stopped eating and went on to require a feeding tube. Next slide. So I'll come back to her a bit, but when I reflect back on her and other patients of ours, what really has inspired us over the years to kind of think about social determinants of health screening, I often think about, how similar to developmental screening, so many of us, we establish relationships wherever we sit with families, but how do we approach this? And a lot of the discussion that came up in the last discussions, and listening and reading what some of you were saying is so true. I mean, how do we approach this? And you'll hear my take on this. Again, really want this to be a reciprocal conversation. How do you put together, right, all of the evidence, all of the sensitivity, the implicit bias, what's going on in the world to support our patients and families, and do this in a way that achieves outcomes that are really have the best interest of the patient and family at heart? I think about the life course, and I just had to bring in the life course. I kept going back and forth about whether to put this slide in, but I think about Drs. Liu and Halfon, who I think about as folks who, in the maternal child health world, kind of are the grandfathers of this concept, right? And I love this particular slide of theirs in one of the articles around racial and ethnic disparities. That's quite old, but I come back to it a lot when I talk to trainees and when I think about my patient and the work that we're about to talk about today. And you saw Linda, I love the socioecological model. For many of us, our training, we think about frameworks, right? And I think those frameworks are great lenses. But then there's the piece of like, what does it look like when I'm sitting in my office with a patient like I just described? And when I think about the life course, for those of you, many of you probably have seen this, but I think about this idea, right? And we're thinking about the things that happen to children before they're born across that whole life course, and then across the horizontal axis there, right? And we talk about the early programming and how it's cumulative, and then looking at the health potential along that vertical axis. And then where I think about are just these ideas, right, of the risk factors being the red arrows and the protective factors being the green arrows, and kind of thinking about how do we, when I think about one of many things, but the social determinants of health screening, kind of really pivoting that life course perspective and the experiences that our patients have, and how that leads into what we're talking about today. Next slide. I shared this slide on my last presentation, but I don't want to be redundant to anything that Linda has shared, but just kind of thinking about, these social determinants and how they kind of preaching to the choir here. That's why we're all here today, right? But how do these things sort of really inform the risk factors and what we screen for? And are all these things in the screeners, right? We're going to talk about that in our breakout session. Which of these factors are we talking about screening? We're talking about economic stability, the physical environment that families find themselves in. You know, what really plays into what we're doing? Transportation versus safe housing, where the lived environment, the education level of our families, or literacy, and how does that access inform the access that families may have? When we talk about food insecurity and community and social context in the healthcare system. So these are all things that we could possibly include in a screener. Some of you may be already screening for these, but what is, and where do we go from here? And is there, and I guess one of the things that's one of my big take home messages in this is that, you know, very similar to how we all, you know, do many things in our lives, there's not a right or a wrong. It's also about knowing your patients, knowing, we talked earlier in the chat in, you know, in what folks were talking about is, you know, I think someone mentioned in one of the chats, you know, screening for things that you might not have resources for. You know, how do you think about which of these things to use? And do you use an already, a screener that's already made, or one that's very tailored to the population or resources where you're living or taking care of patients and families? So how does this translate? And I just want to remind us, the next slide is, you know, this framework that I sort of think about, the Care Coordination Academy. And I sort of had walked through this on my last presentation, and I'm not going to walk through each spoke of the wheel, and I know it's busy, but I sort of think about, you know, how the social determinants of health and what we're talking about today really does kind of crosswalk through all of these things that we talked about on the last time I spoke, but really thinking about, you know, focusing in on that screening, supporting, and addressing social needs and equity. That's kind of what I'm honing in on, but knowing that all of these other pieces through that we're working through on the Care Coordination Academy, what you heard Linda talk about, really kind of inform that screening, because you're linking to those community agencies. Your team members, the activated team members, if you look there in the yellow box, they are part of that screening. The technology, right? How you're actually screening and how you're closing that loop, right? We'll talk about that later in my talk. It's not just making the referral, but did the family actually get the referral that you made, and what was the quality of that referral? Was it effective? Did the family actually, you know, use it or feel that it was useful? And then we could kind of walk through all of them, right? So this is why there's this, in my mind, this schematic is contiguous and connected, because none of these things really is done in isolation. But I brought this back into this talk because I just wanted to remind all of you kind of my lens and sort of, you know, the link to the care coordination, right? It's why we're all here. But just to kind of remind us how this social determinants of health screening and what we're talking about today kind of links to our overarching framework. Next slide. So if you recall my last, oh, here we go. I think my banner, there we go. Linda, oh, yeah, there we go. Stay at that one. I'm sorry about that. On the social determinants of health, I'm not going to recapitulate what Linda said, but I just wanted to kind of remind us about, you know, these are the things that, the conditions that people are born into, grow, live, work, and age, and mostly responsible for the health inequities that we see our patients and families experiencing. And I like the idea and the concept that we mentioned in the last talk, right? Start from a place of positivity. Our goal is health equity. So kind of thinking about, you know, a strength-based approach. And the one thing that I wanted to talk about, you know, that's the World Health Organization kind of framework, which I like. It's a very simple and descriptive definition of SDOH, but think a little bit about how children with special health care needs and those that have more medically fragile lives, how that's compounded. And I'll share a little bit when I talk about our experience about how we thought about that population, those being children with special health care needs, and adapted some social determinants of health screening. And you know that there's limited literature out there on screening, especially for complex patients, which is where we found our experience. And, you know, I think we've talked about this with Linda about the importance of addressing this in the healthcare delivery systems, and that really there are multiple areas where, you know, we know that this has far-reaching and this is why we're talking about it today, that we really, and I think Linda set the framework for this, that, this can help us in achieving optimal outcomes. Next slide, please. So if you do remember on my last talk, you can click through some of the animation. I talked a lot about how care coordination and really can kind of lead to that integrated systems of care. So how does, using my food theme, how does this, play out? Well, if you think about where does SDOH fit, and hence my title, you go to the next slide, we think about, care integration, kind of including, if you remember that wheel, the framework of what I think of as a lot of the things we're doing in the academy together, is including meatballs. And as my vegan daughter reminds me that, not everyone eats meat. And as you can imagine, my Italian immigrant parents, what it was like when they found out my daughter became vegan, and how my mom was trying to convince her that, she wasn't going to survive without meatballs. It's quite a humorous discussion. But I think, the point is my daughter very astutely kind of talked to my mom that it's actually the context of, it could be a veggie ball, or as she likes to say, a meatball with the letter N. So the point being that, in my mind, as someone who's raised with just a strong cultural influence, meatballs kind of, you don't often serve lasagna without a meatball. And with all seriousness, I think about care integration, and why I use this analogy, is just that it includes, and it kind of just underscores that framework that I mentioned earlier. So with that, I have a little Zoom poll. I don't know if my Zoom poll is embedded, but I was just curious.
Yes, I will pull it up next. All right, let's say polls.
I have a bet with my daughter.
Everyone see that?
It's not showing up on mine.
There
we go. So which of the following do you put in your meatballs? Beef, tofu, beef, veal, and pork is how my nonna makes them. I don't make meatballs. I buy them pre-made, or I don't eat meatballs at all. So you could just humor me so that I can, with my daughter, I will come back with some evidence-informed findings from my respected colleagues. So even if you don't eat meatballs, I still think that this conversation and our talk today is very relevant to you. Did we get our results or no?
Almost. We have 101 people are still voting in. We'll give them another 10 seconds.
It's great.
Excellent.
Survey says. You like family?
All right, I'm going to go ahead and stop the polling now.
Okay, great. Oh, elk. Look at that. Turkey meatballs. Yeah, you know what? Thank you. You are right. I should have had turkey as a choice. Should have been none of the above. Sorry about that.
Excellent. Well, thank you, guys.
All right. I don't see our results, but.
Oh, did the results not come up? Hang on.
That's okay.
There we go.
Oh,
can you see them now?
Ah, look at that. Yes. I think maybe perhaps my lack of choice may have changed. Okay. Well, this is good. Thank you for indulging me in my meatball ascertaining. So this is kind of moving on. This is a slide that I think really does underscore. I just wanted, again, another visual framework as you're kind of thinking about approaching this. One of the reasons why I like this depiction of thinking about health inequities, and it comes from the Bay Area Regional Health Inequities Initiative. I love the idea that they kind of think about this upstream and downstream, as you see that there in the slide. And I also like, I think Marie Mann mentioned earlier, the idea of policy kind of being across this, because many of us are on the ground in our areas. But what I love about the Care Coordination Academy and the work we're doing all together is that we kind of think about policy as being sort of woven through what we do. And so also thinking about where I sort of think about some of these, I thought a lot about the schematic, and also thought that, it's so important when we think about what we're screening for, what we are doing with the information and the sensitivity of that information. And I want to share some what I call as unintended consequences for screening and from our own experience. So just wanted to kind of share this, as we sort of think about in here, the sort of the core of this is kind of the living conditions and kind of looking at the community capacity building. And I really liked how, this framework for the Bay Regional Health and Inequities Initiative really kind of looked at sort of mitigating factors and protective factors. It sort of felt like the life course for me, and kind of looking at life expectancy and infant mortality and kind of that downstream. So I just wanted to share that with you as a way to think about utilizing the data that you get, why you're doing what you're doing, and also really being thoughtful about what you screen. And, you know, do you really need everything that you're asking for, and what really are your goals? Next slide. I wanted to share and take a couple of minutes before I talked about our specific experience. I wanted to take a few minutes and share an analysis that we did with one of our, who's now a practicing pediatrician, at the time was an MPH student, who's a pediatrician, Dr. Aaron Pankowitz. He did a project with Rich and I and Hannah and team, where we actually took a look at the National Survey of Children with Special Health Care Needs. And really, I wanted to start with this because it kind of is that like 30,000 foot, you know, data look, and share some of our results that I think really, when we sought out to do this project, we really wanted to look at the links to care coordination. No surprise, right? That Rich and I and others were interested in how social determinants related to care coordination. And we wanted to look at some secondary data, meaning that it was, you know, extrinsic to our individual cities or practices or agencies, and kind of see how this looks. So next slide. This is just a photo of Aaron, who I just wanted to acknowledge in all of his work. And he's doing great stuff down in North Carolina now. Just had a baby of his own. So congratulations to you, Aaron. Couldn't be with us. Next slide. So as I mentioned, not to get too into the weeds here, but just to frame this discussion, because I think some of the findings from this article, and I think we've shared this in your library if it's something you want to look more into, but we took the National Survey of Children with Special Health Care Needs, with many of you are familiar with. Now folks are looking at the National Survey of Child Health. This is an article that was just recently published. And we had created a composite measure based on that survey of care coordination divided into two groups. The focus of the groups was really on children. So again, this is just children with special health care needs. And once you kind of looked at that group, the groups were then divided based on responses to a number of questions. The respondents were mostly caregivers or parents. And we sort of bifurcated adequate and inadequate care coordination. And I could, you know, get into the weeds a little bit more, and you can certainly, in the article, we describe exactly which questions informed that. And there was a third group that didn't receive any care coordination. But for the purposes of today, really just want to focus on this inadequate and adequate care coordination. And part of what we looked at when we defined those groups, that parents, you know, that had inadequate care coordination were parents that said, hey, I need help with care coordination, but they either didn't get it or their experience, as characterized in this survey, was less than satisfied. And there was a lot of different measures around that. And then adequate was parents that, or caregivers or respondents that said, hey, I need care coordination. And those that either were very satisfied or had, you know, adequate communication as measured by the questions that were in the survey. Next slide. So what did we find? There was, you know, there's a lot of, this was, the nice thing about a secondary data analysis is that you have lots and lots of respondents. This was, again, a national sample, so it was looking across the entire United States. But again, in the interest of time, I just wanted to highlight, you know, some of the results that kind of speak to, you know, what we're talking about today. And of all the respondents, of parents of children with special health care needs, parents and youth, children and youth with special health care needs, about a little over 70% reported needing some type of care coordination. And when you look at that group that said that they needed it, about 55% said that they got that adequate care coordination. So if you recall, it's the ones that said, hey, I needed it and I was satisfied and there was good communication. And it was about 45% that did not. So still kind of a bummer, right? Like that makes me sad that there's still so many parents and caregivers who aren't receiving the care coordination that they identified as a need, or they might have gotten it, but it wasn't what they thought it should be, right? And I think that that's so important. It speaks to, I think, what was brought up in one of the chats about, you know, what closing that loop. And what was, you know, it's not just that you gave a parent a resource, but if it stunk, or the parent had a poor experience, or the family, what did it really mean? And what was interesting when you looked at, and why I think this is so relevant to what we do, this article really highlighted a lot of the health inequities related to care coordination. And when we looked very specifically at the characteristics of that group that kind of fell into that 55% that received the adequate care coordination, had a good experience, they had a less public insurance, less chance of being uninsured. They had less poverty, less out-of-pocket expenses. They were less likely to have their work affected or worry about hours at work. And interestingly, we looked at parental makeup, and they were less likely, they had a child who was more likely to have a mother born in the United States, and they were also had an increased odds of having a two-parent household versus a single parent. Next slide. So they had these, really what we looked at in this, and I don't want to imply causality because that's really important. When you look at surveys like this, and we have statisticians that are far smarter than me, really we're doing what's called a cross-sectional look, where you're sort of taking a slice in time, right? So we're looking at associations. I don't want to speak beyond what we did. Again, it was one survey. So we looked at, the associations in time, and really it's an increased odds. So they, to say it another way, these respondents that had adequate care coordination had an increased odds of having a mother that was born in the US, as opposed to, being an immigrant, being non-Hispanic white, having private insurance, and I mentioned two-parent households, or being greater than 400% above the poverty level. So again, if you think about that and take pause, right, where sort of it really, in my mind, kind of is, it sort of just underscores, again, we're going to talk a little bit, doesn't mean that, just screening is the answer. But in so many ways, when you think about, we have parents who, and you could say to me, Renee, what about the chicken and the egg, right? What came first? Or, in this association. But it really does kind of just highlight sort of the privilege and the fact that sometimes we're wedging this divide further apart. And these kind of findings and work motivate me more to think about how do we make this much more equitable. Next slide. And when we dug down into this article, we've also looked at, and there's lots of ways, again, the statisticians, we kind of look at controlling for various variables because it's a large set. And we made sort of what was called looked at families that had that adequate help with care coordination, and their relationship with their providers, meaning there was adequate communication. They felt like they had an environment of mutual trust. They felt like that provider was sensitive to their customs and their values. We looked at some outcomes. And what we found was that, and again, you sort of model this with you can have two comparison groups. So those that had adequate care coordination, had a decreased odds of having emergency room visits compared to those without. And I think I already mentioned this, they had a lower odds of having out-of-pocket expenses. They had lower odds of having financial burden. They had a lower odds of spending greater than 4 hours a week coordinating care. Excuse me. And they had a lower odds of having an impact of work or cutting back on their hours as related to their child's condition. So, I mean, graded, I can certainly, and I'd be happy to talk to anyone more that was interested in how, and the article actually outlines a lot of how we set this up. And again, I'm not stating that this is perfect, but this was a pretty large sample that suggests that, we really need to be digging deeper in this, one of the things that was really interesting to our group was really associating the receipt of adequate care coordination and looking at as associations of with the various health outcomes, as well as just understanding that population, which is why I really wanted to share with you some of the socio-demographic characteristics of the groups. If you want, you can go to the next slide. And so I think in terms of the conclusions for this and what I wanted to share was, this national sample really was something that, I wanted to kind of think about this idea of the intersection of care coordination and the social determinants. And, it suggests that linking them with decreased outcomes, decreased access to care coordination, it just suggests that there might be some linkage there, not causality. But again, what I think about is, in line with a lot of what Linda just talked about. That's why we're all here. We're thinking about the policy, thinking about our screening instruments and our workflow. And excuse me, the next slide. What an ideal world for me is kind of thinking about how do these things kind of, you know, in that circle, the framework that I kind of frame this with, you know, how do these things overlap, right? Where is that contiguous ring that I shared with you, the Care Coordination Academy? When we think about care coordination and really care integration and how that informs the work we're doing here today. And next slide. My animation, I kind of think about it's kind of like our lasagna and meatballs, right? So we sort of think about them as interwoven. You can sort of, they might be done, or they might be eaten, you know, separately, but they're, at least in my culture and in my family, you know, you always have them together. And so I bring us back to next slide, you know, just my patient, right? And kind of thinking a little bit about, as I shared with you, you know, I'll tell a little bit more about her story towards the end, but, you know, I initially received then the call about the trauma that she received when her parents became incarcerated, and she was the next day, and a new foster parent trying to seek care for her and understanding all of her needs. And I, you know, always wonder about patients like her and stuff that keeps me up at night, thinking about if we had done a better job screening a family or her mom, you know, might her outcome have been different, and her mom with her. Next slide. I think I have a Zoom poll because I wanted to see, and I think we actually had some of this on the needs assessment, just kind of getting a sense from all of you. I think we actually shared some of this, but our question really related to where some of you are. And I think I have a little bit of a sense of this, but just wanted to see, you know, what best describes your team. Has your team been screening for, you know, social determinants and feels comfortable? Have you been discussing it, not decided on a tool? You're in early stages, or you're most likely not be screening. And again, you might be somewhere in between, but would just love to kind of get a sense of where people are, and thought it might be helpful for us as a group to see where other people are. See.
So we have about 65 out of 130. We'll keep going.
Great.
Awesome.
Thank you. And I know we're gonna, you know, kind of launch. I just want people to kind of start thinking about where they are in this continuum. And the next portion of where I wanted to go after this, I don't know if we could.
Here's the results.
Good. So it seems like the majority is in the early stages, and some have been screening some. So we've got people along the continuum. That's really helpful. And that's, I think, really commensurate, Heather, with what we saw in our needs assessment. Next slide.
Absolutely.
So I think, you know, where I wanted to kind of segue and transition is into some of our home and community-based partners. And if you remember, next slide, you guys all indulged me on my last talk with my Nemo cartoon. Don't worry, Rich, I'm not going to show Nemo again. But I like to think about our fish, you know, who are together, a school of fish, like you know, I always talk about my work family, and who is working for the common good of our patients. And, you know, if you go to the next slide, I think we've talked about this, and listening to and seeing some of the folks, you know, we talked about community health workers, social workers. Some of you have nurses. Some folks rely on community partners, which is beautiful. I mean, I think I wanted to share some of the folks that are the fish in my world as I segue into sharing our experience. Next slide. One of the things, and one of the fish in my world that has been really helpful for our experience is our medical legal partnership. And I wanted to just take a moment before I describe our experience to just explain a medical legal partnership. I wasn't sure how many of you were familiar with it, and I felt like because they're so phenomenal, I thought it might be helpful. So I wasn't throwing around phrases. And please, in the chat, please, you know, ask anything if I'm talking about things that are beyond. But I was going to share some specific data about that we did with a team doing a deep dive into social determinants of health screening. But a medical legal partnership, and I know there are lots of places that have them. The Harlem Children's Zone, I think, was one of the first places that kind of looked at this. But this idea that healthcare clinicians, attorneys, and social work staff, in our case, we're also working really closely with community health workers, but they work together to address social determinants of health that might have legal remedies. So there's lots of things that folks, you know, that they can address. And so I'll share some of our data from our medical legal partnership of some of the things that we've seen on the ground that have come up. But as people think about MLPs, as I'll refer to them, you know, they can support things like custody, child support, evictions, landlord-tenant disputes, public benefits, so it might be SNAP, children's SSI, special education, advanced planning for children with special health care needs. They help us a lot with guardianship. You know, one of the other things I learned from, for example, RMLP, I know that folks were recently just talking about, you know, the public charge and things like that. I learned, you know, from RMLP that undocumented families were eligible for WIC. Now, you know, keeping in mind that one of the things that I'll talk a little bit about, and you'll see in my discussion, is unintended consequences, right? So there's nothing more that makes someone, especially in our current political climate, nervous about when I say, hey, I'm going to go out and get our lawyer to help you with immigration issues, right? I mean, what do you think most families, it takes a lot of trust for them to want to talk to an attorney. And I've learned a lot from them about how to talk about what they do with families. Next slide. You know, we had a medical legal partnership that started, you know, that really, they had a screener that they were using that was very legal based. And we, you know, really initially at our work at St. Chris kind of focused on a lot of housing issues, food insecurity. We knew where we are here in Northern Philadelphia, our rates were higher than the rest of Philadelphia and the state, Commonwealth. Education issues. We had a lot of families that had legal status issues, home safety. And one of the things that we did was modify this for children with special health care needs. You can go to the next slide.
Renee, do you want to take a quick minute right after your next slide just to do some comments and questions from the chat? Would that be okay?
Yeah, absolutely. Yep. Please.
All right, let's do your next one so we finish this part though for you. Thank you.
So this is just something just to give you, this was our snapshot. We have screened overall at St. Chris. I'm going to give you a deep dive into some social determinants of health screening, but we had some legal screening that we did. We've been doing this for almost about 10 years with them, and we've screened close to 30,000 families at this point. And it's just over half have identified at least one legal need, just to feel like I'm probably preaching to the choir here in terms of the need. But these are just a snapshot of all of the legal. This is kind of just my plug for our medical legal partnership. You know, food insecurity and insurance. And really, we looked at, you know, actual food insecurity versus the worry that food, you know, would be an issue. Looking at public benefits and utilities, custody and support, habitability of their home, education, SSI for the child and the caregiver, domestic violence, eviction and divorce. You can see there, those are our top just things that we have identified and been able to address with our medical legal partnership. So they're just such a key part of my community, my awesome team here at St. Chris, that I wanted to just take a moment to highlight them before I launch into sort of the details of our experience. But you can go to the next slide. I think I have a poll question, so maybe we can launch that poll, Heather, while we're looking at some of the chat.
Yep, Jessica, do you want to start pulling through some of the chat comments? And I think I saw maybe one or two questions and just some comments and some additional resources people are sharing.
Yeah, there's a lot of really great stuff. So I think first of all, Renee, everyone was really vibing with all of the data that you put up. So thank you so much for sharing that. There were a lot of thank yous, a lot of moments that folks were having just around sort of documenting the poignancy during these COVID times, right? People appreciate the deeper dig on the data related to care coordination from NSCH and the social determinants of health implications. Debbie Harris mentions it was interesting that one could perhaps predict that second slide data before it came up, and that as it relates to the access to privilege. So a lot of really great stuff there. Next up, there was a question actually from Beth Johns. I don't know if you wanted to say this for yourself. It was about looking at the severity of issues related to the social determinants of health.
Yeah, I guess,
sure, go ahead, Beth.
Oh, I just wanted to know, like, when you did the study, is there stuff in the article around how you looked at, you know, you sliced and diced the data? If there was sort of, there's no way to really look at people's perception of control or the knowledge of the system of care, that kind of stuff, but it would be cool to keep moving.
Absolutely. I mean, that's a great, and that's the up and down side of doing, you know, the nice thing is of these, of the larger data sets is that you have a lot more data. You can get representation beyond just your little microcosm, but you're right. There's no real marker of quantifying the severity of that. I mean, that's one of the things that I think is really important if you are, and when you think about measurement, and I think it's a great lesson learned to take, you know, for us to do on our own spheres, kind of look at that and share, you know, and think about how to measure it, and also just the degree, sort of the dose, and also that referral loop closure. So I think it's a great comment.
Jeff Schiff also had a comment about the data, and said that he believes it highlights a key and unfortunate issue, the time cost of poverty. I don't know if anyone wants to second or third that or anything.
Yeah, I would definitely thumbs up on that one, Jeff. And just that, and how hard it is to, you know, how, and I think about times of COVID, how quickly we're slipping into that, and how hard it is to reverse it. So agree with you.
All right, I think we'll go back to the presentation unless there's one more question we might have time for. Let's see.
Just scrolling.
Yeah, there's some good, looks like people posted some really good stuff, some good
some
national,
kits.
Yeah, the child health.
Mm-hmm.
Oh, it's comfortable. Looks like people have some tools. I'd ask people to put their tools in. I think we probably have some of that, right, Heather?
We do, yes. We asked in the survey that we sent out just to list the tools if they are screening right now.
Mm-hmm.
All right.
Yeah.
All right, we can keep going, and then if we have a few more minutes at the end, we can have some more time for questions and comments.
Great. Yeah, so I wanted to just talk a little bit about our experience to open some dialogue and transition. And this is like the second part. I wanted to acknowledge, next slide, Rebecca Golden, who's now Dr. Golden, who was also did this as part of her Masters of Public Health project to really get us kind of going on this deep dive to SDOH. So yeah, thank you, Rebecca. And she's now a resident. So you can go to the next slide. And so really what were we seeking to do, and what I was going to share? I mean, we really wanted to kind of do a more exhaustive approach to social determinants of health screening, where really we're focusing on a subset of children with special health care needs. We were trying to take a longer tool and kind of look at what pieces might be relevant. And we also wanted, you know, part of our goal in doing some of this was to look at it, but then also follow up, you know, and sort of see an improvement, not just screening, but actually to get to the point that I think was mentioned earlier, you know, did that actual screening, giving the resource, actually make a difference? And what did the family think about the quality of the resource? And so we looked at looking at unmet need, and we looked at, you know, implementation of standard of care, of interventions that we had in our office to address that. And then we really were trying over time, and we're still trying to collect this information to look at long-term impact of caregiver burden and their whole experience of healthcare and improved outcomes. And that's just taking a little bit longer, but I wanted to share that. And one of the things, you can go to the next slide, that we did was we really, you know, I think this was talked about earlier. You're going to hear this in my reflections and my comments on all of this, is that we actually created this. This was something Rebecca created when we met with some of our parent partners in our practice to really, you know, we had been so focused on the workflow of the office, but we really, I think I kept this slide out because it was so important for us to think about the workflow for families. I mean, as obvious as this sounds, sometimes in practice, we get so focused on like our experience that we actually forget the family's experience. And so we actually did this, you know, we timed it, and whether some of our parent partners got this feedback on, you know, saying this is going to take 20 to 25 minutes. And this is when we're going to do it. And we initially had talked about doing some stuff in the waiting room and realized that we were asking some really sensitive questions. And so in our sort of quality improvement approach, actually end up having the survey given at the front desk, but completed in the exam room. And we talked about, and we're very intentional in saying things like, you know, we're going to have you meet with support staff to help meet your needs. And we actually leveled the playing field because we went with such a longer approach that we realized it was impossible to have all of those needs met in the visit, or else parents and caregivers, even if they wanted to, they would have been there for hours, and we didn't have everyone at our fingertips. And we just leveled the playing field also to say, hey, you know, we wanted to complete a follow-up survey because we really care about your experience and what this meant for you. So next slide. And I really wanted to just, y'all see in my my reflections here, I have no problem kind of saying when we did things. I think it's important to recognize what you do right, but sometimes you learn more from what you do wrong. And I'll tell you, there's so many lessons learned, and I thought about this, you know, I don't want to vomit on you today with too much, because I wanted you to kind of think about things that I wish we had thought about before. But one of the things that I think is so important for us was, and to be sensitive to, the fact of family expectation, right? There's a lot of literature written about this, about ACEs, right? The adverse childhood events, where, you know, thinking about some of the nature, some of the questions that we're asking families, sometimes they can be triggers, right? Triggers to the past, trauma, you know, that we're asking families questions that they might have been in therapy for years ago, or maybe they never sought therapy, or maybe they've never even disclosed. And their expectation, not just that we're asking it, but when, right? That, like, you know, hey, I'm Susie's mom, and I'm going in to see Dr. Turchi for her 12-month well visit today. And I'm thinking, like, oh, I want to talk to her about the fact that she's not tolerating her feeds. I think she's getting her 12-month immunizations today. And you know what? Like, insurance denied my home nursing, and I want to talk about that. And that's in my, you know, maybe I'm writing stuff down, or I'm thinking on my way over, this is what I'm going to talk about. I come in, and all of a sudden someone I don't really know is asking me questions about all kinds of stuff, you know. And you go to the next slide. I just, you know, and I'm not trying to be overly dramatic here, but I think about, for those of you from Pennsylvania, you may have heard of Wawa, but that's where I like to get my gas. But I would just say gas station, right? So when you're like, I was thinking a lot about this, and, you know, and we had lessons learned, and when we talked about it internally, I was thinking, you know, I think about my own upbringing and things that people you might think, or no, I'm Italian because I talk so much with my hands and I talk quickly. But if I was going, you know, not everyone that knows me knows that I'm a first generation American, right? And I think about, you know, if I'm going to go get, you know, my routine when I get my gas is to go to Wawa and get my gas. And I would never go, I go in and there's a gentleman there that I know, and he's my friend, and we always chat. But I would never expect to go in there and pay for my gas and get my coffee and have him start asking me about my parents' immigration status and mine and what my citizenship is. You know, and I know this is an overly dramatic example, but I was trying to think about my own life and times where, and for me, that doesn't also trigger per se, but a lot of our families, a lot of the things that we're asking are really sensitive. And so I think that that was something for us that we really, our parent partners really helped us. And I can't underscore that enough in terms of the sensitivity, and that, you know, sometimes, especially in research, we can get so carried away with thinking about all the things we want to know. And some of these things can be actually, you know, cause harm, and also can be very sensitive. So keep going, next slide. I think for us, that was a really big thing. You know, when I talk about families being central, you know, we involved families early on. As I said, you know, they talked about their own workflow, and that was great feedback for us. You know, we had some wherewithal to have them vet how to do it, but it was, I mean, they were, you know, even more important than like the evidence-based tool, brevity, those kinds of things. It was about, you know, how to approach this. This is so much deeper than, like, you know, talking about vaccines from the world that I sit in, and, you know, and I really think that that's important. Next slide. We worked a lot. I mean, this is a busy slide, but I just wanted to highlight this for you. Like, our experience, you know, for us, we call it the clinic workflow. And another big lesson learned is kind of thinking about how important it is wherever you sit, whether it's practice or agency, that everybody knows what you're doing. You know, like, I think that it was interesting, you know, we had a lot of meetings with like our social work team and community health workers and our medical legal partnership. But we also realized that, like, our MAs, you know, my practice, our families are so bonded to them. And, you know, the medical assistants kind of knowing that this was going on and what their reflections on, and kind of working through this. I mean, this sounds, if you kind of look at some of what I've written here, they discuss the screening study with the family, you know, they complete the process. We also use the PICS as, you know, data to have the family talk about their experience. So really, you know, just making sure that all the team members know what you're doing. They're all really involved. And think about the fact that, you know, some of what you might be asking can be sensitive to a family. You know, it's so important that some of their trustworthy folks, you know, and I like to make sure, you know, all the doctors in the room know that it's, you know, sometimes it's, you know, it's not always us that they want to talk about that with, and that's okay. And I think it's important to be comfortable in your skin, that, you know, the staff, you know, and just kind of working through that. So I guess, you know, less important about what you work through, but I think just that, like, you kind of are really very methodical in that workflow, and when things are going to be given, how they're going to be collected. You know, for us, I mean, we had intimate partner violence questions on the survey. So we really had to be thoughtful about how they were asked, where those papers are. I mean, we could really be putting women at risk. Next slide. We also collected things, you know, for us, we looked at, this was along the road, we were, you know, this was really important data. So for you, we did collect some of this not from families, but we wanted to make sure we were trying to get a sense of, you know, just even for us, where there are older patients, parents of younger children, who was actually answering this. And, you know, the education question, I put this up here because I think it's just so important. I mean, for us, you know, when I look back, we got a lot of feedback from our parent partners. I think, you know, our medical legal partnership and others, we really had a lot of, I won't go into the details. I struggled a lot personally with whether to keep the education on our assessment. I feel like for many of us in the research field, you know, it becomes one of those core measures, but I kept this up because I wanted to share with you, you know, yes, we kept it, and I'm not advocating that that's relevant to everyone. And I can, you know, at another time talk about why we did, but it's just think about these things, and don't just include sociodemographic factors because other people have, or it's in the literature. Think about, you know, whether it's really relevant to what you're doing. Next slide. We did actually look at, for us, a lot of the income stuff was relevant because we had a big part in ours that was relevant to SSI and income, because our medical legal partnership needed a lot of this information for their legal, who they could help and how they could help them. But again, this was, you know, thinking about this, and also thinking about literacy, and you know, and thinking about who's completing the tool and who's actually they're answering on behalf of. Next slide. The other thing that was really relevant to us, and this is a map of Philadelphia here, we spent some time looking at our families. I mean, St. Christopher sits in one of the poorest congressional districts, and this is just a poverty hot map, and we just really wanted to get a sense. We did a lot with some of the work that we do. We look at, you know, zip codes where our families live so that we can help refer them to resources. There's a lot now if folks are looking at, you know, electronic referral to resources, things like Aunt Bertha or other electronic tools. And so this was just something, you know, think about that in terms of your referrals, because I think one of the things our medical legal partnership taught us a lot is that it doesn't always have to be them giving the resource. So thinking about where folks are, and, you know, if I have a family that lives in the zip code at 19134, you know, let's say the mom screens positive for postpartum depression, it is relevant that I'm not going to send her across town, and I'm thinking about, you know, transportation or how families are going to get places. So geography matters when you're thinking about resources. Next slide. We looked a lot at poverty level, and and looking at, as I said, where families reside and what zip codes they were in. We've worked really closely with who our funds are, MLP. A lot of this becomes relevant to the unmet need, but some of that might not be as relevant to what you're trying to accomplish. Next slide. I just wanted to share a snapshot of some data and really spend the bulk of time on, you know, some of the reflections that I hope will be helpful as you think about things. Sorry, this is small, but, you know, this is about 245 screeners that we did in our deep dive. And this was our care coordination. And we found that, you know, having, you know, of that 245, we had about, you know, a little over 13% had home nursing needs. Some had in-school medical support, about 5% had a need identified. Medical equipment needs was just under 10%. Medication refills was small. Keeping track of appointments was about 12%. And obtaining the correct formula for children that were gastrostomy tube or, you know, technology dependent was a little under 10%. Next slide. So we then, you know, looked at social work consults. So we sort of looked at all our fish, if you will, and sort of divided our screener by who was going to be responsible for addressing those particular needs identified. And that, I think, was really important so that you could map the identified need to who is responsible. So again, we looked at things like you can see here, you know, diapers were something that we happened to screen for because we have a diaper bank, things like that, transportation, utility shutoff, food insecurity. But we as a team sat down and said, okay, you know, our social workers were on board with these are the things I'm going to be responsible for, nursing, care coordination. And then you'll see the next slide is our medical legal partnership. And we spent a lot of time with our teams looking at, you know, the things identified. And you can see here that for us on the legal side, the landlord getting home repairs was a top identified need, but also as well as for custody, immigration, and separation and divorce. But we were very intentional about how we organized it, because we organized our screener, because it really was informed by our workflow. We had multiple iterations of how the questions were grouped, because those folks that were responsible for helping our families wanted them all in one area. So that really lends, you know, again, comes back to your workflow and who you're working with. Next slide. I wanted to talk again about some unintended consequences. Next slide. We had, you know, identified some things that were really, you know, very intense. We had 4 active cases of intimate partner violence that were identified through our screener with families who had been in our practice for a long time and were screened verbally but had never disclosed. It highlights a lot of, you know, what some folks describe as some families are more comfortable reporting on paper, or maybe, you know, it highlighted for us just, you know, how are we screening? Are we screening and being sensitive to who's in the room? We also had one very severe case of postpartum depression that was identified that warranted immediate, mom was at risk to herself. And we had urgent utility shutoffs. So it really highlighted for us, you know, we then, as we started doing this, realized that not only did we need to look at who was doing what, but we highlighted some questions and we had someone scan the screener before the family left. We had identified kind of these hot ticket, like this mom cannot leave or this caregiver cannot leave if any of the screens to this small cohort of questions is positive, because we realized that those were emergent needs, as opposed to, you know, other things that could be done with a referral or a follow-up loop later. Next slide. I think just some reflections. I wanted to just kind of end with some of my reflections. You know, measurement is key. I think that for us, what we found is that kind of looking at this, you know, so often like anything in life, when you start looking at the data, you know, it sort of highlights, you know, it's way bigger than you think. Understanding the family experience, for us, we use PICS, other folks have used other things, but getting that family feedback. Next slide. And I think, you know, as I mentioned, triaging, what needs to be addressed now? When you start asking questions, remember that some of these, you know, for us, we learned this the hard way, that some of these, we went back, as I mentioned, and identified these emergent needs. You know, the capacity and internal process. I say here, I bought a lot of cannolis. Think about your partnerships, because once you start screening, I mean, I think, you know, I had social work support in my office, but this really, we started asking a lot of questions that in many cases exceeded our capacity to address some of the needs. So thinking about where else you can refer, but also that the family's okay with you making those referrals. I talked about this already, the intimate partner violence example. You know, some practices or some agencies might do electronic versus paper versus verbal. Think about literacy issues. You know, I have recently had the experience where I had, you know, I walked into a room and a dad was filling out a paper version of a postpartum depression screener. And I was like, huh. And I came out and I was talking about this with my community health worker, and I was concerned that, well, like, why would this dad be filling this out? It turned out the mom, there were literacy issues. So thinking about, you know, those kinds of things where, you know, are there literacy or language issues? How is your tool being done? And think about documentation. You know, protecting families is key. If you start asking very sensitive questions, things about immigration status, things that can be recoverable, things that, you know, if there's intimate partner violence going on and you scan something into an electronic health record and a male or woman has not left that relationship and now a partner asks and has access to that record, you could be putting people at risk. So you have to be really thoughtful about what you're scanning, and just really have to think about wherever you're storing this information, how you're doing it. Happy to share some of our experiences on that. Next slide. I think, you know, I talked about this already, who does what, who administers, who collects, who addresses, being sure you're clear about that at the outset, because you can't all be touching your nose. If you're going to ask, you should have a resource or have a reason for asking. You know, training for that non-emergent, you know, it might be that if you identify food insecurity, it's just a matter of anyone can give a resource to a local food bank. How do you quantify the severity? I talked about this already, I think, can't underscore enough. That electronic referral, closing that loop. It's not just about screening and getting this data saying, wow, there's a lot of landlord-tenant issues. What are you going to do with it? Also think about frequency and screening fatigue. You know, we really spend a lot of time with our parents on this. You know, how do you ensure, you know, we had in one of our resident practices where, you know, there's such a big practice that they were just giving social determinant screeners at every visit. It was way too much. Families were just like circling no or circling yes. And we realized that, you know, you have to really be conscious. People are tired. Parents are there often with children in tow. And so what's the meaningful and what's the sweet spot, you know, for the numbers of times, what you screen for and how often? Next slide. I think that one of the things, you know, to think about is always think about who are your fish, right? And we did a lot of this, thinking about, you can go to the next slide. I think I have animation in there, right? So think about, you know, who's there. And I think these are just some final reflections here. Children with special health care needs for us, you know, we added guardianship questions. We added questions related to equipment. I think you saw on there with our nursing, we added home nursing. We added things like formula. So think about your population and what might be relevant. Remember trusting at all levels. And you know, a lot of this takes motivational interviewing, implicit bias training. You know, everyone should be, if you're going to screen, it shouldn't be that people with certain insurances or certain colors of their skin get screened. That is, you know, unethical. And think about language and literacy and how you're going to address that and support it. And also think about confidentiality with your staff. You know, here at St. Christopher's where I practice, we hire a lot of folks from the community, and think about the sensitivity of that, of who's collecting this information and how, you know, important it is that families' confidentiality, regardless of who it is, and just that families are filling this out and they know what you're doing with the information. You know, we actually, for our social determinant health screener, actually had an institutional review board review it with us because we just felt like as a team that was important because we were asking some sensitive stuff and we didn't feel comfortable doing it without some third-party support in this particular pilot. I'm not saying everyone has to do that. I'm just sharing our experience. And next slide. And I think, you know, remember, I think this was brought up earlier, all of this now in the face of COVID, right? So we did this prior to COVID. And this is, you know, now I just think it's like, you know, just even more. And I just bring us back to, you can go to the next slide, our, you know, what I started with, right? This is all integrated into this framework. And how I think about our experience and what we learned and just, you know, I think we're always going to be learning. We didn't hit that ceiling and go to the next slide. Just bringing back to my original patient who's doing so well now and is within a new family. And when I think back to, you know, again, the upstream, right? The prevention and what we could do, but just being intentional about how you're doing it. And I think I kind of touched on my last slide is just some wrap up. I think I touched on all these things, but I would just say, you know, as you set goals, thinking about the tool you're using, which I think we're going to talk about in breakout, the timing and the support you have in your team members. Remember that words matter and how we do things. Think about, you know, the equity, implicit bias, language, and culture. And by language, not just, you know, just thinking about literacy as well, unintended consequences. Think about that training and the confidentiality and who's on your team and that communication across those teams and your community partners. Think about the roles of partners and how you're going to close those loops and who best can meet the needs. It might not be the people that are in your agency or in your office. I think I can't underscore the engagement of families enough. Plan with them, talk about what you're going to do and build that trust so they can be prepared, you know, to know what you're going to be doing and you can rebuild, you know, trust if you make a mistake, but it's important to think about it at the outset and keep swimming together. And remember that meatballs can be veggie balls too. So I know I gave you a lot of information, but I was trying really hard to think about what I wish we knew. And that's really the end of what I had to say. So I don't know if there's other,
Renee, thank you so much. That was amazing, as always. There are lots of chats, comments, and comment questions. I will definitely go through them all though, and I think we'll use the discussion board to try to field some of these together, and I'll also field them with you, Renee, and I can post your responses so everyone can see them there.
Sure.
So in the interest of time, he has Renee's contact information as well. All right, and then we will send you all to break. Why don't we come back at 3 instead of 2:55 since we went over about 5 minutes. So if you come back at 3, we will then ship you all out to your breakout groups. Thank you, everybody. All right, we'll give everyone about another 30 seconds, and then we'll come back and then we'll start heading out to our breakout groups. And Bethlyn, I'm going to hand things over to you. I think we'll get our teams into all of their breakout groups first. And then we just want to let the teams know we're going to have some faculty popping into your group. So someone might appear. We will introduce ourselves and we'll offer some assistance and kind of hear about some of the work that you guys have been doing.
Great, thanks Heather. So I just popped breakout instructions into the chat box. So you will not be able to access this once you get into your breakout room. That chat is an independent chat function just within each breakout. So you'll want to click on that and open it up on your computer. And then I don't know if you, Heather, want to just add the file too, just in case folks want to try to open it that way too.
Sure.
That'd be great. So I have done my best to assign people. You'll see that you folks now have some sort of state or initials of some sort, special code before their name. If I didn't know where you were going, I'm trying to identify people by their state or if they're with the Spina Bifida Association. You know, they're all going together. So if you don't have that, you could just rename yourself in the chat. I'm going to send, first what I'm going to do is send everyone to the breakouts right now. And then I am going to, once you get into your breakouts, if you find you're in the wrong place, feel free to just leave that breakout and come back to the main room and let me know. And at any time you do leave the breakout, then I'll just need to put you back in. Right now, I have to be the air traffic controller and get everyone there, just so that everyone's aware, okay? And then I will monitor, so if you have teammates that aren't back on, as they're coming in, I'll be able to send them along. They can just let me know in this main room, and I'll make sure they get where they need to go. So what I'm gonna do right now is I'm going to go in and tried to make sure that I assigned everyone to the right room. So I'm going to open all those rooms now. You should see something pop up on your screen in just a moment that tells you, and you can go into that breakout. And then the next thing that we're going to do after that is message you for time within those rooms. And if you need any help, you can, there's a little button to ask for help from us, and you can, or someone could pop back into the main room if you want to. And Heather, did you send those instructions?
Yeah, so I'm trying right now. I keep getting a network disconnection, so I'm not sure if someone else is able to send the file. I know I emailed it to you. I can email it to Jessica maybe too. It won't come through on mine.
Yeah, I can do that. It's just I'll take a minute to have to pull it up, and let me do that.
Someone was able to open them. Okay, maybe it's half working.
I can send it. I got it open.
You got it open? Okay,
Yeah.
Thank you. Okay, it's opening for some people. Excellent.
Great. I'm glad to see it's working for some folks. But we'll Jessica's gonna put it, attach it as a file for those that might need it. Yeah, I figured some folks might need it. All right, so I'm gonna wait a minute because once I put you in a breakout, you wanna have access to the chat. So Jessica, do you wanna throw that into the chat? No, I'm sorry. It's not the link that they need. They need the file.
No, I know. I'm just sending the link one more time, but yes, the file as well. Hold on.
Okay, great.
Thank you, Jessica.
Yeah.
Excuse me. All right, I'm going to open the rooms, and then those who are ready to go can go. If you need the file that we're going to put into the chat here, hang around, because once you get into your breakout room, you won't be able to access the chat from in the main room. All right, and then I'll start putting people back.
Okay. So the instructions are in the chat.
All right, so there are a few folks, let me just see. who I knew. I was not sure. All right, and a lot of folks are not joined, so. If you are finding that you're not invited to join a breakout room, please let me know. Jolene, let me put you. Okay, so there we go. Mac, Florida. And then I just had, oops, sorry guys. Once we get a bunch of chats, it makes it a little more tricky. Let me go back up. So I got Michelle. Okay, so Jolene, I'm gonna do first. I have to put up. Okay. I'm gonna have to come back to you, Jolene, because you're not showing up here for me. I don't know what's happening. Michelle. Okay, so Michelle, you're heading to Florida. All right, and I got Mac, Mackenzie is going to Montana. Okay, Albert. Yeah, if folks hopped off and then hopped back on, any assignment I did for them was nullified. So, yeah, so that's, there's only so much you can end up doing in advance, unfortunately. All right, what else do I have? All right, so who am I missing? Candy Bush. Everyone's so nice. Please and thank you. So I'm going to see, let me see if anyone that hasn't joined, I'm going to see if I can help you get in. So I've got, okay, so she's going to New Jersey. Okay, Barbara's moved. Okay, Chuck. All right, I'm gonna unassign and reassign Kathy. Unfortunately.
And just for me, for anyone watching the recording, I'm going to stop recording now and then we will restart it when we do our closing remarks.